So great to meet you.
Hey everyone, welcome back or welcome to my channel. Have you ever heard once a cesarean, always a cesarean? I interviewed the birth nurse. She's an incredible nurse, and I feel that a lot of nurses don't get the recognition that they deserve. During this journey of options in childbirth, or this little docu-series that I've been working on for like months, so like non-stop, I've encountered a lot of really cool nurses. In this video, we discuss true and false information that is often shared when you are pregnant or about to give birth. So a lot of it is like common misconceptions around pregnancy and childbirth, and even some unsolicited advice, which I know we all encounter and it sucks. I'm really excited about this interview. Mandy is incredible. Again, thank you so much, Mandy, for letting me interview you. It was really nice to meet you. I've ran into a lot of health problems recently, and I've been having a lot of technical difficulties. I've been really slow with posting, but I want to get back to it. I want to get back to interviewing more people. If you have a birth story that you want to share, please email me. Visit optionsinchildbirth.com. Read all the stories that are already shared. Watch a couple more of my videos if you just now came across me. Let me know what I can do to do better. Constructive criticism is always good, and I'm always learning. Thank you for watching, and I'll hopefully see you next week.
My name is Mandy Irby. I am the birth nurse. I do a lot of things. I'm a labor and delivery nurse and a childbirth educator, and I'm working online and teaching online in order to help families and moms to have a more confident experience when they give birth. Birth boldly is what we say. So I teach online at the Birth Nurse Academy, and I'm also on YouTube, like Ashley, at Mandy Irby. So I'm in a lot of places, but really excited to talk to your audience today because I love your channel, Ashley. False. I love debunking these. Next. No, I think that, oh man, I've seen so many young people, small people, big people have babies and just surprise everybody in the room, all of their family members and all of their providers. So it's totally case by case. But being too small, I think it's more about the shape of your pelvis. And that's very hard to determine without an x-ray, which you probably are not going to do when you're pregnant. And the position of your baby and the health of your pelvis. So there's a lot of components, and it used to be really common to say the baby's too big for your pelvis, but we're finding out more and more that that's much less common than we thought. So I think that's like an old truth.
Okay.
Or an old understanding. No, I don't think that you are going to be too big to have a vaginal birth, but you love my caveats. I always have caveats. This will show you how unique every birth is, right? It really depends on how comfortable your provider is with caring for you. I think that I really encourage people pregnant people, birthing people, parents that want to be birthing people, to open the conversation really candidly, just like you are a customer, a paying customer asking for a service, and just being very direct with your provider. And that way they can be very direct back about their comfort level, because our external fetal monitors, which hospitals love to use very regularly, as you probably know, they are not very good at monitoring bigger moms. So there are some providers who are very uncomfortable with that reality. And there are providers who help prenatally, the mom be as low risk as possible. So it's really up to your team and also your risk factors. I wouldn't think that it would be that simple, but it may come across as that simple. I think it would be more likely that there are other risk factors like higher BMI. There's more risk factors for gestational diabetes, larger babies, preterm babies, preeclampsia, and then the inability to monitor the baby. So if she had like if she had a high risk factor, like she had diabetes, and the recommendation is to induce labor to decrease the risk to the baby. So during an induction, the provider would want to monitor the baby and monitor the contractions all the time, or most all the time, especially during the active stage of labor. And if it's not possible due to the limitations of the monitors, then the provider may suggest and recommend a cesarean at that time, because they can't definitely say that they are safely helping both mom and baby during the induction because they don't know, but that's still a discussion and still a choice. She could still go forward and decline monitoring. I mean, there's all kinds of things. I don't necessarily recommend like a path because everything is so unique to that specific situation, but I think that information comes prenatally. I think the planning is huge for that so that they kind of know the limits of the monitors, the limits of hospital staff's understanding and, really openness about it. So touring a place and talking to your provider, you'll get a good feeling for that. Yeah. I will say the hospital that I'm at, we're in a small town and it's in a big hospital. We just got monitoring equipment that's specifically designed for larger BMIs. So, you can imagine the worst case thing, but just really understanding where you're going, who you're going to be with, and how they feel about, the limitations of their equipment. You might find out that, the tubs are bigger, the equipment is getting better, the beds are getting better. It might be better than you think. There are very few instances where that would be recommended. It would be like breech twin, like it used to be recommended for estimated large babies, but it's not anymore. I love debunking because everyone, like, there's so many more choices these days. You'll hear me over and over, but the conversation, the planning, the decision starts way before you're having your first contractions. Mm-hmm. But no, you don't have to have a C-section after a C-section. There's even numbers that your provider can give you, like a calculation, and it's not exact. And it's, we love numbers and we love to like fix everything with like this little box and put you right in it and tell you exactly how it's going to be, but we can't, but we try with this calculation of induction risk. And so your VBAC, your weight, your previous pregnancy, your previous health, all goes into that calculation if you are like contemplating an induction, which is a very hot topic right now. It's like super popular for your provider. Even I've heard it like 18 weeks to start talking about an induction, which is like, if you're concerned about that, 18 weeks is a great time to have that conversation because then you can know where your provider stands on all of that and how comfortable they are with, going into labor on your own versus induction might be what they see the most. But some providers still do not play by the most recent research, and they do not practice ACOG standards, and they do not offer support during a VBAC or a trial of labor after a cesarean. You and I are both in the South, and I think it's way less common here than it is in other parts of the country. And it's a really heavy and convoluted topic. I know if doctors like if my friends are watching, they're going to be like, it's more than that. It's totally so many factors. Like it's recommended that you have anesthesia on staff at all times, on call. Like, it's a system-wide effort to do really well by a VBAC mom. And hospitals are businesses. So if it's not good for business, that sounds bad, but I think we need to like really speak the truth, and it's about business a lot of times. And so they do hold really high like liability insurance, but I think that's just the fear more so than the actual like liability, because there are much more risky things that take place than VBACs in hospitals. So I think it's fear-based, and I think it's system problem. And that's why I love teaching parents, because I really think they're the game changers.
Mm-hmm. Yeah.
Like, you're fired up about the fact that they took away VBACs from that birth center, and one person in the hospital can make that decision. But what about, 10,000 birthing people in your community? They really have more voice and a larger voice than they think. They're the paying customer. A lot of places, it's not that black and white. It's really awfully gray. Like home birth, the kind of support that you have in a home birth, not all places are the same. It's not always a safe option. Hospital birth isn't always the safest option. Birth center isn't always an option at all. So there are so many lanes in real life, and we're just talking about like the idea.
Yeah.
So dramatic.
Yeah.
I don't think I do a good enough job preparing people for that possibility, but no, yes and no. You love that. I know. Yes and no. Yes, nuchal cords, or the cord around the baby's neck, can be very dangerous. They're very common, however, and so a lot of times they're not dangerous at all. So that's not very clear, but the dramatic part is when the babies come out blue or purple, which is physiologic, normal. That's how most babies come out, but you're not seeing like two babies come out at the same time. You're just seeing the one with the cord around his neck. Yeah. So most babies come out purple, and then they don't breathe oxygen through their neck. So it's dramatic for us, because if I were walking around with something around my neck, like that would be hella dangerous. But they're breathing through their cord. Yeah. So as long as there's space for the blood to flow through their cord, then they usually like grow fine with a cord around their neck. It's just happens while they grow, because their head is so huge compared to the rest of their body that if they're like doing their flips and it loops around, it's difficult to come unlooped. But for most babies, it's not an issue. It's just very surprising when they come out. And most moms can't see, like that's not their angle. Yeah. So it's usually the partner or like the support people who are like, oh. Generally, no.
That's good.
Generally false. I did look up the numbers, however, recently, and it's a possibility. Like it's like 1 in 80,000. So that's someone. Yeah, that's very rare to have permanent damage. I think people picture, and I even just saw a picture recently that was an epidural needle that went into a space right before the spinal cord, which isn't super accurate. It's actually below where the spinal cord ends and the nerve roots begin. So you can have nerve damage, definitely, but it's not going to like sever the spinal cord. My caveat for the epidural will be that you, and I shared this with a patient just this week, and she was like, oh, wow, that changes my, thought process around the decision for an epidural. Is you are the epidural medicine works like a paralytic almost, in that it limits your ability to move and feel from the waist down while you have it. Okay. So people say, oh my gosh, I feel paralyzed, because they thought maybe that they were going to be able to move and feel like normal, but without the pain. But you can't really take away the pain without other sensations. So it's like at the dentist, when you get numb, you also feel like your mouth is huge, like a balloon.
Yeah.
they took away the pain, but they added that funny, weird sensation so that you might feel like you're paralyzed when you have it. And I think that adds some fear right after people get an epidural, but that's what an epidural does.
Will you be able to feel like if you're ready to push? I think that a lot of people are like, if I get the epidural, I won't know when to push.
A lot of people can't feel that pressure. The goal is that you do feel that pressure. A lot of people feel nothing. But if you have like 2, 3, 4, 5 epidurals, most mothers say that they were all different. It reduces sensation, but hopefully allows for pressure. Sometimes that pressure gets very intense as the baby is moving through the pelvis, or there's tight spots in the pelvis all the time. There's all that soft tissue that the baby's kind of moving through, which can radiate, and mother can feel in other places like her back or her hips. And so you may need more epidural medicine. There's different amounts that they can give you. So it's hard to know what you'll need. And so they give you one amount, but really they're just estimating what you'll need. You may need more later on.
Right. That's really
Doesn't mean they need to replace it though. It's super easy. It's like, boop, you're done. Only a little bit goes in. It just needs to be long and straight, just like your IV. If I put that whole needle in your arm, that would be uncomfortable, but just a little bit. But I wouldn't want to see it.
I just didn't feel anything at that point. I was like, I'm just so ready to have this baby.
That's so good for people to hear. Yeah. I'd say it's never necessary, except everyone would hate that answer. It's recommended in a lot of situations, especially I feel like we have more comorbidities, we have more diabetes, we have more preeclampsia. We're seeing moms with more things going on, more inductions. Those are times when when your provider and your hospital policy recommends that you have continuous monitoring, but you don't have to have it all the time. Yeah, that's the discussion that happens. Like, just because they put the belts on doesn't mean you now have to have continuous monitoring. You definitely should ask, like, how long do they stay on? What are my options? What can I take these off? For how long? I think that your provider should know your questions and goals up front, and maybe not at your like trying to conceive appointment, but why not? I mean, it's an interview time. I think every appointment is an interview. Do I keep going with this person? Do they have my best interests at heart? Do they really get me and my goals and what I want for this experience? And if at any time that shifts over the line to, ooh, like, you should be excited to go to your appointment to get more information and talk to the person that is going to be a support person on your team. And if you ever go in and you're like, unless they're about to like dry your blood, if you ever go in and you're like, this is going to be horrible, or you leave feeling not better than when you went in, not because you maybe got bad news, but just that relationship isn't any stronger, reevaluate what's going on with that relationship. And so you should be able to have that conversation, or they don't have to have all the answers. They can just refer you to, hey, it's too early to tell, but this is what we normally do, or go on a tour of your facility and you can go anytime. The amount of time you go through choosing your childbirth education instructor or your doula or your car salesman or your college, like, those are times when you pay a bunch of money and you spend a lot of time making sure you feel good about who you're dealing with and your decision, and talking to someone up above if you're not getting the answers that you want. Yet we just somehow lose some of that when we go into a prenatal appointment. You deserve to have someone, they're going to see your most intimate parts and talk to you about your most intimate stuff. Yeah. But I totally did the same thing. I enjoyed my provider the whole time, but I did not learn enough, and I was a labor and delivery nurse. Yeah. I was not prepared either. And I thought that, I don't know, that you would get there and something would just tell you what to do. And no one knows the best answer for you except you. So Yeah, your provider knows a lot. Your nurse knows a lot. I'm kidding. But they can recommend things according to what their specialties are, but your specialty is like how you feel about it and what's important to you. They don't know your priorities.
Yeah, so let them know so they can accommodate to your needs. I think that.
Yeah, if you're going in every appointment fearful that you're too big to have a baby, you should be able to say that to them. They can see inside your vagina, right? Like you should be able to say, I'm really having this fear about tearing. Can we talk about that?
I love that. Yeah.
Right? Because every time you're going to go and it's not going to get any better because they're not going to bring it up.
But thinking back, my provider was like an authority figure, like
Yeah.
over me, it felt like. But at the end of the day, your provider is a person too. Like everyone works there. We're all people. So it's okay to talk about these things.
Yeah. And I think you're going to learn more about them as a person when you really, give them some of those pains that you're having and some of those fears. They're going to be able to talk to you like a person instead of like they're limited too. They're so limited by insurance and Medicaid and all of the like numbers is what they're limited by. And so they have allotted 8 minutes. I don't know what the number is, but they've allotted 8 minutes for your appointment. And if you let them steer, then how are they going to be able to answer all of your fears and your questions? But if you steer some of it, they might be like, I was terrified about that too. And then you're like, wait, you've had a baby?
Yeah.
And the whole relationship is improved, even if they don't give you an answer that is you like, at least that relationship can be stronger, and then you can move through finding answers that work for you. No, I don't believe that. The mucus is there to protect the cervix, so you make more of it. It's also different for everyone, so it can look like discharge, or if you've recently had intercourse, it can, the day after or the night after, you'll be like, oh my gosh, is this my mucus plug? And there's so much pressure on mucus plugs to like tell you so much. But I would say if you're preterm and you think you lost your mucus plug and it's accompanied by pain or pressure, backache, cramping, bleeding, that's definitely something to listen to. But otherwise, it's just one of those things that your body does at the end of pregnancy to kind of get ready for labor. No, it doesn't work. No, that's jumping on trampoline. Yeah. No, that's just going to hurt your pelvic floor, I think. If I knew the secret to inducing labor at home, I would be a billionaire. Like we're all trying to find that. No, I would say go curb walking instead of going on a bumpy road. If you're term and your baby's head down and you're just ready to get that baby out, go walk up the steps 2 at a time. Do that. Not like hard. You can't like pop your baby out. Dates, pineapple. Oh gosh, there's so many.
Not so good.
I just did a video on this with the blogger at Baby Talked Out Life. Hannah and I were just talking about this. And I just messaged her and was like, we need to do an update because there is a new study. We looked at the Cochrane Review about this. There is a new study about perineal massage during pushing that said that when you're a provider with permission and with your consent, and only if you want it, if the provider does perineal massage while you're pushing or in between pushing, it can reduce perineal trauma. That one can reduce, it increases the likelihood of an intact perineum. It's tricky though, because if you do the studies for perineal massage during pregnancy are not super clear. It only improves outcomes for first-time moms, not second-time parents. So it's still kind of like, if you want to, you can later in pregnancy if you feel like it might help you.
Okay. What about birthing in a position that makes you comfortable? Would that reduce tearing?
That is a great way to phrase that question.
Okay.
In a position that's comfortable. So like, I think physiologic birth, if we don't touch birth, or we let the birthing person just kind of do their own thing, I think that is a great way to reduce tears. So yes. But so yes, and that works with like and that's true for like culture. So if your culture is a culture that you like squat while you're eating, you squat to go to the bathroom, you squat to play with your kids, then squatting might be a super beneficial and comfortable position for labor and for pushing. But like in our culture, we don't squat ever. So that is a position that doesn't reduce tearing, increases pressure on the perineum, and it is not comfortable. So I always say a position that makes you comfortable. Even if I think, oh my gosh, she's on her back, or oh my gosh, I don't know what this is going to do for her perineum. Like you can do other things to help protect the perineum, like a hot compress. And I've seen women give birth with their legs completely closed. Imagine that perineum. Like that was probably awesome. Position that makes you feel comfortable should be a priority over the position that you think is going to reduce tearing because of the perineal support, because of like time and just patience for the baby to come out. Super huge factors for reducing tearing. But yeah, watching the birthing person, some people arch their back. And you always see people like curl up and have your baby, but some people just need to arch their back. Some people need to close their legs. Some people frog their legs out in a way that is like superhuman. I really think that if you're listening to that internal, like, I got to move, we don't go into birth, I think, saying like, oh, I totally trust my body. Like once you're in it, I think transition just breaks you down and tells you, don't trust anything I say. This is horrible. When you look back, if you were in charge of the positioning, or even if you just said like, I don't like this, and they offered you different things and then left you to be what works for you, then I think that's overall best for everything, best for your outcome, best for the perineum, best for your experience.
Okay. Thank you.
You might need to like slow that baby down. Maybe that's why you're closing your legs and laying on your back. It might have like shot out of there like it can. Listen to what feels good. No. Even if someone tells you you have to be on your back, you don't ever have to do anything. But if someone says we recommend you be on your back, then supporting evidence might help you make that decision. You know, if it's for monitoring the baby or doing a procedure, then that should be clear. But no, you don't have to. No. Even if you have an epidural, there's all kinds of ways to have babies without being on your back. In my hospital, we help with upright births in the bed. But I've heard in some hospitals where their epidural rate is a little, like the medication rate is a little lower, then they could be in a chair or next to the bed. I've never experienced that, but it would take people. Like if I'm the nurse in a room where we are trying an upright position while pushing, then I'm using whoever is in there to help make sure that she's safe, because she's not going to be able to like catch herself, or if her leg slips in the bed, she's not going to be able to have that muscle strength with an epidural to be able to be like, oh, my leg's slipping. So I kind of like maneuver people so that she can still be either sitting really high or supported squatting in the bed, or in hands and knees, kind of depending on the epidural and how she's able to move. But yeah, it takes a lot of people.
Okay, so but people do have options, and I think that's something that's important to remember and to consider when going into any birth, is all of the options that you have that you should look into, and evidence-based stuff too. That's important to remember.
And if you're my patient, like, you're going to get so tired of me coming in and being like, why don't we try this? Why don't we try this? But a lot of nurses in hospitals have multiple patients they're taking care of, or are not used to patients who are asking for things that are different and that require more people. So it may be up to the family to say, we've read about this, can we try it?
Okay.
Instead of like just waiting for someone to tell you. And just taking time. So whenever you have to make a decision, just take some time for it, talk it out. Is it what you expected? If it's not, get some more information, know the risks, know what it would mean. And, thank you for the information. I think we're going to do this. It's not the hospital's forever experience. They don't, they have to do things on an average, and your birth is not on the average. It's your one big day. Get an amazing childbirth education class and ask questions. That is what I would say. Get your team together that's going to be with you in your birth, and surround yourself with the type of birth stories that you want to be your birth story. So learn all you can. I think people are afraid to learn because they'll hear about stuff that's scary, but you're going to take that fear with you into labor, no matter if you debunk it or if you ignore it. It comes up, all your stuff comes up in labor. So getting rid of it, working through your fears, getting more information, and then forming a really strong support team with you in your room. And then you're never going to be able to be ready for every single thing that could happen because you don't know what's going to happen. But planning on, practicing making decisions and knowing what to expect in your body and what to expect from the hospital or the place that you're going to give birth, I think are your strongest powers that you can do with knowing so little about what will happen. I think that is a huge fear for people. So ground yourself in some knowledge, and then trust your team that you bring with you. I wasn't reading all the books, and I wasn't learning I didn't take Lamaze when I was pregnant the first time. And those are things that I changed once I had a baby, and was totally oh my God, I had no idea this is what it was going to be like. I think once you learn of all the things, you learn of inductions and you learn about breaking water and all the interventions that could happen and all the things your body does and all the feels you're going to have, I think the scary part is the limits you think you have on that outcome. Where can I make a decision, or who's going to make these decisions for me, or what choices can I actually have in the process. So that whole learning, but also practicing making decisions for yourself and speaking up and asking questions. It's not an attack on anyone. It's not a personal thing. It's an assertive, just like you are in your real life. You're going to honk at the person that cut you off. It's not personal. As my husband would say, don't ever honk at anyone. It's not personal. It's safety, right? And so when you make decisions about safety, then you can feel a little more assertive about that and a little more comfortable. But you have to practice with people instead of policies or machines or big hospital, big business. It's people that want to care for you.